Okay, so I think a few more people will be meandering in, but just to get you guys started on time so you guys can enjoy your evening. My name is Emily, obviously, as you've seen on the slide, and has been on some of the promotional material. And today I wanted to talk about tachycardia in psychiatric patients. So I know a few weeks ago, the other Emily kind of gave you guys a bit of a talk on schizophrenia. Did you guys attend that one? You can do like the little hand wavy button or thumbs up or whatever. Okay. I'm also like very technologically challenged. So if something goes wrong, I'm so sorry. I might be a little slow responding. So I'm hoping that this talk can kind of build a little bit on that one while kind of incorporating some new elements. A lot of times people kind of separate some of the ideas that psychiatry is kind of very separate than medicine and then surgery. And for a lot of patients, there's a huge intersection at play. As one of my patients lovingly told us, the psychiatry team is not a real medical team, and that is definitely not true. So let's kind of divide some of those myths today as we walk through a case together. So to tell you a little bit more about myself, I graduated from the University of Rochester in 2021. I was there to get a BS in biochemistry with an honors in research, a BA in psychology, and an ethics minor. It's a great program for all you high school students out there. Open curriculum, so you can do whatever you want, which I so clearly did. And then I went to medical school at Emory University, where I'm in the MD PhD program currently. The way we do it is that we do 3 years of medical school, then go to our PhD, and then finish up a final year as our M4, and we apply to residency from there. So I'm currently in about halfway through my clerkships, and I have a few left. I'm happy to chat with any of you guys about the MD PhD path, and I can give you guys my email, or you can reach out to Becca if you'd like to connect with me about that. I've been working with Motivate MD for over 2 years now, where I work as an editor, an interview coach, and an advisor as well. And that is me with slightly different colored hair on the right with one of my clinical advisors from this year, who is a phenomenal doctor. So I had to give her a shout out. So today we're going to walk through a case. I'll provide you with some physical exam findings, the way you'd approach the differential diagnosis, and then the final assessment and plan. We'll also talk a little bit about pathology of disease. And since mine builds off of some of the previous talks, we won't go into as much detail there today. So please just actively participate, drop things in the chat. I'm someone who doesn't mind if you guys want to unmute and you find that that's more interactive and a better session for you. And I'll put up the QR code so you can do the form in a second. But just a question for you guys, and let me open a poll. But how do you guys think you can differentiate between what is a psychiatric emergency and then what is a medical emergency? And you can answer in the poll. You can chat about it out loud, whatever you guys want.
I can actually say it.
Yeah.
Sure. So for me, in my opinion, a psychiatric emergency is like when someone is having like thoughts are going to have suicide or mental behaviors and all that sort of thing. And a medical emergency is a type of emergency that deals with like almost like any anything other else. Like let's say for your legs or your arms or anything like that. And yeah, so I think also psychiatric is like with trauma, something that deals with the head, the brain, and all that. And medical is overall included with everything else. So yeah,
So kind of differentiating it out by like parts of the body, like where are the symptoms coming from? Is it from the brain?
exactly.
Is it from something that's a little bit more somatic? Yeah, that's definitely one way that people look at it. I'm also like I said, so bad at technology. So if I'm slow answering your questions or seeing the answers, please ignore me. Let me see if I can answer. Ooh, see some of the results here. Okay, it's being a little slow. But that's one way that you can think about it. And then another way that we think about it, and can you still see my slides? Okay. Another way that you can think about it also is, what is kind of the etiology? Because you'll actually have a lot of overlap in those. Sometimes psychiatric conditions can almost present with what appears to be a medical emergency, as well as vice versa. And we'll kind of tease apart some of those ideas as we move forward through this case. So however you guys prefer to do this, I'll leave this up for like 20 seconds. So hopefully you guys can scan it. And if you're not a QR scanner and struggle with it like me, there's also the link that you can type into your phone or your laptop. And once you guys have done, just do like a thumbs up or raise your hand so I can see who has completed it. Okay, any issues with accessing the form? So the case we're going to talk about today is AM is a 24-year-old female brought in by family to the emergency department after exhibiting aggression at home, hitting objects with a baseball bat, and yelling incoherently about the Bible. Upon admission to the psychiatric floor, patient has an inappropriately elevated affect with delayed responses to questions. She endorses hyperreligiosity and states that there are angels that have been talking to her. She notes that she first heard these voices 4 months ago and that they have come and gone since. So before we get to the question at the bottom of the slide, I always like to ask, are there any questions about the language that's in this history here? Because I know I used to always be too embarrassed to ask and I'd be Googling things and I want to make sure you guys can follow along. Okay, awesome. So what would you call this presentation if you had to use like a vocabulary word that might have come up in the past lecture or just even in your own words? And I can give you guys some hints too. So things that I would pull out from this prompt as a medical student is something that we look for, and we kind of call this constellation of symptoms a specific term. And it's defined by having disorganized speech. So you're not able to follow someone along in conversation. It's not really making sense. Delusions are like odd beliefs. So things that we see here in this case would be hyperreligiosity. So kind of thinking more broadly about religion and thinking having a more in-depth or nonsensical connection versus just having a faith in a particular religion. Disorganized behavior. So behavior that doesn't seem quite to fit in proportion to the situation that's going on. For instance, I would really hope or not suspect that any of you guys are hitting things with a baseball bat right now, right? That behavior wouldn't make sense in the context of a calm meeting. And then hallucinations. So these can either be auditory or visual. So either they're seeing things that aren't there or they're hearing things that aren't there. Any guesses as to what this constellation of symptoms is typically called? Oh, come on, I know it's late at night. Someone has to have a guess. Delusion. So that's a part of it, right? So those like odd behaviors. Um, so when we have more than two of these symptoms, we call it psychosis. And this is a term that's used a lot in psychiatry, and I feel like you're not taught about it a lot. But this presentation can typically occur with several different things. So you can have psychosis due to underlying medical conditions. You can have psychosis due to primary psychotic disorders, and that's what we're going to chat a little bit about in the next slide. So this kind of builds on the talk that you guys got from the other Emily about schizophrenia. But when we think of primary psychotic disorders, those are disorders that are mainly characterized by psychosis. And those are different than other disorders such as depression or bipolar disorder, which might have psychotic features, but that's not the main driver of the disease. So in this case, I mentioned that the patient has been experiencing these symptoms for 4 months. So schizophrenia kind of lies on this timeline where you don't become schizophrenic until you hit that 6-month mark. So what you'll hear is some people might have a brief psychotic disorder, and that's where they'll be in a psychosis, but only for a time period less than a month. A lot of times these tend to be precursors to the development of a psychotic disorder, but not necessarily so. It can be an isolated incident or could be due to something else. We also see schizophreniform disorder. So this is where our patient would lie within this 1 month to 6-month mark, where they're starting to see these symptoms of schizophrenia, but it isn't a more chronic condition and doesn't become schizophrenia until that 6-month mark. And then if you go to the DSM-5, who knows what the DSM-5 is? Anyone who's taken a psych, yeah.
Yeah.
Anyone who's taken a psych course has probably heard of the DSM-5. The main like wordy criteria, right, is that you have to have one of those positive symptoms. So these 3 symptoms that kind of define psychosis, and then you may or may not have negative symptoms. When you think of positive symptoms, you want to think about things that are there that shouldn't be there. So this disorganized speech or behavior, these hallucinations or these delusions. They're things that the patient has and believes in that are there but shouldn't be there. On the other side, negative symptoms are things that you would normally expect to see in a patient, right? They should want to do things, they should want to leave bed. But some of these patients have a really hard time with that. We call that negative symptoms. So they might not be able to move the way that they want to move. They may not be able to make facial expressions that they want to make, or they might just like lack motivation and interest in getting out of bed and doing their activities of daily functioning. And those are what we consider negative symptoms. Do you guys know what an affect is, by the way? I know that's been on a few slides, but does anyone want to define it for us? I was so confused about this like before I did my psychiatry rotation, and I just want to make sure you guys know what that is if I'm using that word.
Yeah.
Could affect mean like your demeanor almost?
Yeah, like really close. So it's a kind of your demeanor, so the way you're kind of like presenting. And we usually talk about it in terms of like our facial expressions. So on the first slide, we talked about like during the interview intake, she was inappropriately elevated. So in this case, the patient was smiling, seemed almost like happy to be there, which doesn't really coincide with the situation of being in a psychiatric facility. When you see flat affect, you typically see someone you're talking to them and you almost can't read an expression at all. They're not really moving their eyebrows, they're not using motions, they're not smiling. And that's what we typically mean by a flat affect. So, and I'm not going to dive into schizophrenia because you've already really had that talk, and I really want to focus on the physical symptoms that are coming out in this patient that we'll learn about. So AM is admitted to the inpatient psychiatry ward. Notably, she has a history of schizophrenia in her family and endorses THC use. She has a past psychiatric history of PTSD, secondary to sexual abuse, and ethanol use. She started on risperidone, 2 milligrams BID, for management of her psychotic symptoms. However, her symptoms continue to worsen. AM endorses command auditory hallucinations to kill herself and harm others. She is responding to internal stimuli on the floor and acting oddly, including an incident where she roamed the hall for several hours, holding loose mustard in her hand and mumbling to herself. The decision is made to titrate her risperidone dose to 3 milligrams BID over the course of the next few days, as patient appears to be a risk to herself and endorses suicidal ideation several times to the team with a plan. So before I get to like the next bolded part, why do you think it's important that I pulled out her family history of schizophrenia and her THC use in the first paragraph?
THC use and schizophrenia are like found to be linked, and also family history is like a big important part of like who you are.
Yeah, perfect. To everyone who responded to that. Yeah, so genetics, they don't really know there's no schizophrenia gene, but if you have a family member with schizophrenia, your risk to develop it is actually a lot higher. Also, THC use, especially with chronic THC use, it kind of affects the receptors in our brain and the neurotransmitter release in a similar way that can lead to the development of schizophrenia. So whenever you're screening a patient, and I want to include not just kind of this case, but some useful things that as you guys hopefully get into med school and go on to the boards, will know to pull out of a history when you're taking it. Other things here to note is like a history of PTSD. You always want to make sure you ask about in patients. not only can you have schizophrenia, but you can also have mood disorders as well. So things like PTSD, major depressive order, like typically you don't see bipolar disorder, but you want to like look for all that overlap and anything that might be confounding some of your treatment options. Does anyone know what risperidone or Risperdal is? That's totally okay. You do not need to know. It's an antipsychotic, and it's a second generation antipsychotic. So it's a drug that a lot of patients are put on when they're experiencing psychosis, and it's really useful for treating those positive symptoms, so delusions, hallucinations, and disorganized behavior. Typically, you'll see doses within like the 2 to 8 range. Does anyone know what BID means too? Because I feel like this is used a lot, and if it's never explained to you, it might be a little bit confusing. I know I'm throwing a lot of vocabulary at you guys. I'm sorry. I wanted to make it interesting tonight. So BID just means twice a day. And I do not know why we can't just say twice a day, but you'll see this in notes when you get to medical school or a lot of case reports. So it just means once in the morning and once at night. You'll see when people are in active psychosis, sometimes having 2 doses can be more useful instead of just doing one. There's not really a logic behind that. Pharmacologically, like you'll still reach the same steady state. Don't worry about that if you're not a biochemist. But a lot of patients like to take something in the morning and at night because it's kind of the signal like I took something that'll help, especially if the voices are really distressing. So in this patient, right, we're really worried about these suicidal ideations and these command auditory hallucinations. So this is almost a first episode of psychosis. It's pretty severe. Because, I mean, could you imagine being in an unfamiliar situation, having voices tell you to harm yourself? It can be really distressing. And this is something that we saw in this patient throughout the course of her hospital stay. Is the first few days she was very, very distressed. So as we're looking at this patient's case and we're kind of getting familiar with her and getting more vital reads, we notice that she's been intermittently hypertensive and tachycardic since arrival to the floor. Does anyone want to give me their impression of these vital signs? And this is a very small patient. I know I'm sitting, but she's like my size, shorter. I'm 5'2", 110 pounds, and like I got some meat compared to her. Yeah, the heart rate is really high. So if we're looking at these blood pressures as well, yeah. So our heart rate's like 130, 100. We have a few normal readings, but we're still seeing pretty consistently tachycardic. And for someone whose baseline is about 60s to 70s, this is something to be a little bit worried about, right? And obviously my presentation is called Tachycardia, so hopefully you guys would expect to see that. And yeah, as Mohammed pointed out, the blood pressure is really high on day one. So it's 165 on 99. What's a regular blood pressure? Yeah, 120 over 80. So that's pretty elevated, especially for someone who's younger, in shape, no previously medical conditions. We really are not expecting to see any blood pressures above that 120 over 80. And while we do have some normal readings, we don't have the time on them. If she's sleeping, that could affect them if she's more relaxed. But we're seeing some concerningly high blood pressures that have remained on days 1. I'd even say 2 and 3 is pretty high for someone who's in shape, whose normal blood pressures are 110 on 70, and then back up on 7. And this trend continues throughout her hospital stay. And she was there for about 20 days till I get to the conclusion of the case. But I didn't want to make you read through that much. Whenever you're looking at vitals, it's great to look at the abnormals, but it's also really important to look at the normals as well. So if we're looking at the O2 saturation, we can see that she's able to breathe, she's able to ventilate, so she's getting enough oxygen to her cells, which is something that we really care about, right? We don't want to make sure a patient's not in shock. And that the temperature is normal. So temperature will kind of give you an indication about any signs of inflammation, possible infection, and that sort of thing. So one of the first things that we do when we intake a patient, as well as when we're concerned about vital signs, is do a physical exam. So I'm going to read this to you guys. And if anyone else can be their impression when we're done, you can let me know. So the physical exam is broken down in these components. Has anyone run you through the components before? Yes, no, maybe so. All right, well, we're gonna do that tonight. I find this is so useful, even if you don't take notes and you're just listening, the more you hear, the better it'll be. So general is basically when you walk into a room and you're saying, is this patient sick or is this patient not sick? So grossly alert and oriented times 4. That just means you go into the room and they seem to know who they are, what time of day it is, where they are, and what's going on. So usually you can kind of just assess this by talking to them and seeing like, do they have some concept of reality? If you ask them questions about themselves or their day, can they answer it? For those of you who worked as an EMT, you'd always just be like, what's your name? What time of day is it? Where are you? What happened up to calling us? And then not an acute distress just means does generally not appear to be sick. So HEENT, don't call it heat. I mean, you can, it's cute, but it's just an abbreviation for basically here to here. Is like basically you look at the cranial nerves, you look at the eyes, the ears, the nose, and the throat. So cranial nerves here, 1 to 12 are intact. For this part of the exam, especially in psychiatry, what you really care about is testing for neurological function. So you'll see some way more in-depth physical exams for this portion, especially on pediatric cases and internal medicine cases. But grossly, what we're looking at is, do they have all their eye movements? Because those are controlled by cranial nerves. Do they have strength in the muscles of their face? That's another thing controlled by cranial nerves. Trying to think of what else. So 1 is smell, 2 is your optic nerve, so you'll do a little vision test. You'll do eye movements for cranial nerve 3, 4, 5, and 6. They all do eye movements. 7 is your facial muscles. 8 is your hearing, so you'll just ask them if they can hear you, and you can do some other tests as well that we won't get into. 9 and 10, you just have them swallow for you because that's also the vagus nerve, which is really important. We'll come back, but I'm not going to get into the nitty-gritty. And then your shoulder and tongue muscles are also controlled by that. So this patient has grossly normal neurological function in her head. For her cardiovascular exams, that's when we look at the heart. And what you always do is you want to listen, look, and touch or palpate. So listening to her heart, she has a normal S1 and S2 heart sounds. Does anyone know what those sounds are, like colloquially? That was like a difficult question if you ever heard, but it's like the lub dub sound that you hear when you like listen to a heart. Like you can hear it to your own, or if you put your ear to someone's chest, you can hear the S1 and S2 heart sounds. And those sounds are just created by the closure of the valves. So I don't think I have a picture of a heart up here with me, but you have 4 chambers of the heart. The atria and the ventricles are separated by 1 valve, and when those close, that's the S1 sound. And then as the blood leaves the ventricles and goes to either the lung or the body, another valve closes on each side, and that's the S2 sound. So they have normal heart sounds, basically. And then they have no murmurs, rubs, or gallops. So murmurs are any noises that are there that aren't supposed to be there, and then rubs and gallops are just 2 specific types of noises that you might hear. When it comes to the pulmonary exam, that just means listening to the lungs. Whenever you're doing a cardio exam, you should almost always do a pulmonary exam, just because things that back up in the heart can cause things in the lungs to back up. So listening to the lungs, they're clear to auscultation. Auscultation just means sound or listening bilaterally. You always want to listen to both sides and compare them. And then she has good airflow, so we're not worried about her not being able to breathe or being in any sort of respiratory distress. Then abdominal exam, you'll basically kind of just like palpate around, make sure there's no pain, bowel sounds are normal. Musculoskeletal, we're going to focus on a lot for psychiatry, right? Because she's a psychiatry patient. And all your muscles are controlled by nerves. So she moves a little slowly. You notice her gait's a little slow. When she moves her hand, it's a little slow. And that's something that we often see with schizophrenia as part of the negative symptoms, but can also be comorbid with depression, is also a sign of that as well. No abnormal movements. So we always look to see, are there any weird twitches or things that could be side effects of medications or symptoms of other medical conditions. She's able to move all of her joints normally, and she has 5 out of 5 strength. And then reflexes for neurological exam, 2+. She has good sensation and her skin is pink, warm, and dry. So what is this physical exam telling you? Are you concerned about anything like in particular, just looking at this data? And you can say no, or I don't know. Yeah, nothing's really standing out. I agree with you, Lauren. So everything's pretty normal, maybe a little slow in terms of motor function. Yeah, as Annabella was saying. But that's not something that we're typically too concerned about yet. And I'll kind of dive into some of the things we can be concerned about with different motor abnormalities. But just being slow, it's kind of a symptom of some of the schizophrenia form spectrum disorders, as well as signs of depression. But something that we really care about for a psychiatric patient is a different type of exam. So in addition to your physical exam, because you should do a medical workup for every single psychiatric patient, is that you want to do what's called a mental status exam. Did you guys talk about this with the other Emily? If there's any experts, you guys can walk me through. But the mental status exam is basically when you go through and you look at different aspects of someone to kind of see how are they functioning and what's their mental status like. So there's some parts that overlap with our physical exam, but it's a little bit more unique. So first off, we kind of divide up that alert and oriented part that I put in the general part of a physical exam. So the patient's alert, they're awake, they're moving around, they can talk to us, they can interact with us. Then we go into orientation. Again, do they know who they are, where they are, what's going on? And then we go into appearance. Why do you think appearance might be important for a psychiatric exam?
If they appear like disheveled or something, maybe it means they're not taking care of themselves or something else is like going on in their brain that isn't going to allow them to do so.
Yeah, exactly. Like if I showed up to this meeting and my hair was a mess and I was wearing like a swimsuit, you'd probably be like, what's going on? Like something seems off, right? It kind of gives you some insight into how someone might be feeling. Some people like really extrapolate on this. Like I had a professor who taught this who was like, if they're wearing yellow, they might be like too happy and manic. Which like maybe that's a thing. I haven't personally seen it. But you can kind of get an idea of like what is someone choosing to wear. Are they able to take care of themselves? Is it showing you something about it? Um, yeah, exactly. The sense of self idea. If they're really mismatched and really bright colors, like people who are manic might be wearing like 50 different outfits because they couldn't decide what to wear and decided they wanted to wear everything. Like I've seen that before in the psychiatric ward. So just kind of take in an impression of like, okay, how do they seem to be putting themselves together on the outside? Is that reflecting something that might be going on the inside? In this case, our patient's well groomed. She's taking care of her hair. She's in oversized personal clothing that she brought from home, but is able to tie up her pants with an elastic band that she's provided with. And then behavior. So what is the patient doing while you're interviewing them? So in this case, the patient's lying in her bed upon interview. She seems to be responding to internal stimuli here. When we say responding to internal stimuli, that might be they're looking off at a direction where there's nothing that you can see there, where they seem to be whispering or almost turning to hear something that you can't hear is what we call RTIS, you'll see, but just responding to internal stimuli. Other behavior that's important to take note of is, are they fidgeting? Do they seem restless when they're talking to you? Are they really guarded? Are they turning their body away from you? Are they crossing their arms? Those are really important things to see, judge, not only what the patient's psychiatric status is, but also how are you going to approach that interview? The way I go into a room with someone who's really excited to engage is going to be different than someone who seems like they're not quite ready to talk or a little bit more guarded, and you'll have to tailor your interview approach to that. And then there's also some other language that you'll hear, but I think this will come up. And if you're able to do a good mental status exam on your psychiatric rotation, it always looks really good. And then motor, like we talked about, are they moving slowly? Are they moving quickly? Do they have kind of like a weird walk? You'll sometimes see it in catatonia where they're not able to balance properly. So they'll walk almost like it's called like a shuffling gait. So kind of taking note of that here. And then speech. So the way we're talking now, I would say spontaneous, normal pitch, normal volume. Um, what do you guys think delayed speech might be indicative of? Why would you want to note that? Are you guys having some delayed speech right now? Yeah, it could be a slow response either, right? That's why I love psychiatry. There's no right answer. So yeah, they could have maybe just not being able to process as quickly. So like, especially if you're catatonic or having those negative symptoms, you might have a really hard time getting ideas from your brain out of your mouth, right? That takes a lot of neuronal coordination where you have to interpret the question, right? Goes in through your cochlear nerve, goes to your primary somatosensory cortex. It's got to go to the frontal cortex. Then it's got to go through the motor pathway, control the muscles that cause you to speech and say the word, right? So that's one thing that can happen. They could be overthinking, right? So let's say someone's experiencing a lot of hallucinations or a lot of paranoia. If they have other people talking to them, maybe they are listening to those voices before they're responding, or maybe they're thinking, why are they asking me that? Like, what are they trying to get at? And overthinking their response to the question. And yeah, maybe there is some sort of impairment that hasn't been picked up on yet. So noticing, are they responding in what you would assume to be like a normal timeline? So here she's able to answer your questions, but she's speaking very quietly. Her answers are often a little bit delayed. Mood is what you say when you ask a patient, how are you doing today? And you put that usually in their own words and quotations. So the patient says good, that's their mood. Affect is kind of then where we get to come in, like we were talking about earlier. I think Lauren had mentioned, we're kind of like their demeanor. So what we almost interpret to be their mood. So here I have restricted affect. So she's showing emotions, but it doesn't seem to full extent. It's kind of in between that flat affect and what would I assume for a normal person. So if she's saying something really sad and maybe she's like mildly frowning, but it just doesn't seem proportionally correct, I might say that it's a restricted affect. Thought process means disorganized, so I can't easily follow the train of thoughts. So there's different subsections of this that you'll hear, and if you're interested in it, you can definitely like look this up. There's tons of resources on the mental status exam. So disorganized in general can just encapsulate like I can't fully follow their answers, like their story doesn't really make sense. It's not chronological, it's not narrative. Which write your secondary applications and personal statements in a very narrative chronological way. Small plug. But things you'll hear is like tangential. So you ask them how was their day and they talk about like a bird outside the window. Like they just kind of take off and it doesn't relate at all. You also might hear of circumstantial or circumferential thinking. And that's when people might say, you say, how's your day? They talk about the bird and then they're like, but to answer your question, I'm feeling good today. So they go off, but they're able to bring it back. And manic patients, what you'll hear, and do you guys know what manic or mania is? Just like vaguely. Okay. So those are people who have like a lot of energy, they're distractible. So they'll just kind of keep building and building on what they're saying, and it's really hard to interrupt them. So they might be like, oh, there's a bird outside my window. The bird is blue. Oh, there's a blue ball outside. Actually, I really like playing ball. And I played ball when I was in middle school. When I was in middle school, I had to like they talk really fast. The ideas are going from one to one to one, and they're hard to follow. And those are just subsections of disorganization. Sometimes it's hard to parse them out, so you can just say disorganized. And I didn't want to put you too much in the weeds on that one. And then thought content is kind of the space where you're saying, like, what are they thinking about? What's really going on? So if they have any delusions, so this patient had hyper-religious delusions upon arrival to the floor, right? She was endorsing the belief of angels that were talking to her, very religious, which was abnormal for her per her family. She also endorsed some paranoia. So she started thinking these voices were out to get her, that there were other patients that were out to get her, which this paranoia can be really common in psychiatric illness. She also endorses some suicidal ideation on the day that this mental status exam was taken, but she doesn't endorse any homicidal ideation. So she wants to harm herself, but not other people at this time. We typically put hallucinations under perceptual disturbances, but sometimes you'll see it under thought content as well. And then what I think is really useful in the mental status exam, or something that I like to think about, is insight and judgment. So what do you think if I was talking about the insight of a patient? What do you think that would pertain to? I promise it's not a trick. Like if I asked you if you had insight, what do you think I'd be asking you about? Okay. I'll try to give you an example of this. So if I said I'm applying to med school and I have a 4.0 GPA and a 528 NCAT, I have really bad stats. Do you think I would have good or bad insight if I genuinely believe that those are bad statistics? Yeah, I would have bad insight, right? So when you think about insight, it's kind of the ability to self-reflect on yourself. In the context of psychiatric patients, we typically think about the ability to be aware and kind of reflect and understand their own psychiatric illness. So this patient still did not really attribute these voices to the fact that she was having a psychiatric emergency or struggling with a psychiatric condition. So we'd say that's poor insight. And then on the flip side of that, judgment is like the ability to make decisions that make sense or are appropriate. And if you lack insight, you almost always lack judgment. So if you know I have a psychiatric illness that's worse by smoking weed, but I don't connect those two, those aren't related because I have bad insight. So you keep smoking weed, that would be poor judgment. You're making actions that aren't in line with having good insight or with what you need. Does that make sense? Sorry, this is a long walkthrough. But the mental status exam is like so important and like no one ever teaches it to you until you get to your psychiatric clerkship. But I honestly think this is even useful beyond that. Like in any clerkship to be able to walk into a room and be like, pick up on how a patient is acting. And we'll get into it, but there's actually a lot of times that like the first presentation of some medical conditions or emergencies are psychiatric symptoms that you might be able to pick up on in a mental status exam. So once you're done with a physical exam and you've done your mental status exam, something important to do as part of a history is called a review of symptoms. And you guys can like, if you want to pull one up and look at it, it's basically you just ask patients general ideas like, have you had a fever? Have you had difficulty eating, swallowing, going to the bathroom? Just to kind of capture anything else that might be going on that you missed in your targeted interview. So upon review of symptoms, the patient mentioned she's been experiencing intermittent chest pain that feels like her heart is racing and notices that she's been going to the bathroom more frequently than usual. So these are just pertinent positives here. I didn't want to belabor you with every single negative. So we know she's had some changes going to the bathroom and then she is having tachycardia. We know that because of the vitals. And she's also now reporting that she's having this racing chest pain. And we call those palpitations. So what are some things that we might be worried about with this patient? There's no wrong answers here. If you're worried about anything, you're doing good for your patient. Yeah, the hypertension we're worried about, right? It's not normal for someone who's small and good health has been drinking enough water to have hypertension. She should not be getting a blood pressure of 165 on 99 any day of the week. That's not good. What else did we notice about this patient? What's the name of the presentation? Yeah, tachycardia. She's had this elevated heart rate, and there might be some symptoms that are associated with that. So let's talk about things that we want to work through. Let's start with psychiatric. So we know this patient most likely has schizophreniform disorder. We also know she has a history of PTSD and she has some substance use issues. But what are some things that are psychiatric or mental things that might cause your heart to race? Anxiety. Yeah, right? Like these things don't have to be isolated, like we talked about. So panic attack is one of them, right? So that's when you kind of have these brief, really intense episodes of anxiety. It can feel like your heart's racing, like the world is ending. And something I'll note too, even as a psychiatric patient, they don't have good insight and judgment. So what they might perceive as like the end of the world or what might be a delusion to them could also be a manifestation of anxiety that even people without psychiatric illness experience and phrase that way. She also has a history of PTSD. Does anyone know some of the criteria for PTSD? Or one that might be relevant here? I know this is a tricky question. I made this a complicated presentation because I thought it'd be a little bit more fun. One of the symptoms of, yeah, PTSD can be an increased heart rate. So basically, these patients are hypervigilant because they're really worried about that trauma or that stress coming back. So they have sympathetic hyperactivity. So basically, their heart will beat faster, their blood pressure might be a little higher because they live in the state of constant stress or worry that that's going to happen again. And then we know this patient has paranoia, right? She told us that she has some paranoid delusions, which can also cause anxiety. So maybe this racing heart rate just correlates with some of these psychiatric symptoms that she could be experiencing. Then I put in stars this big long term that has anyone heard of this? Neuroleptic malignant syndrome or NMS? Cool. So neuroleptic malignant syndrome is something we are really worried about in psychiatry. So there's a lot of antipsychotic drugs that can have really bad side effects, and we'll go into those a little bit later. But basically, if you give someone antipsychotics, they can develop this condition called NMS. And it doesn't necessarily relate to the dose, but just the fact that you gave them antipsychotics, and it basically causes a really high heart rate. It causes hypertension, fever, their muscles will start breaking down. Like we are really worried about this in psychiatry. So it's something that always goes on the differential when you're worried about a medical condition in a psychiatric patient. What about medical things? Maybe this isn't even related to psychiatry at all. What are some medical things that could be causing a fast heart rate? A heart condition. Yeah. We don't have to like nitty gritty. I know you guys probably haven't gone too much into it, but does anyone know what like an arrhythmia is? Yeah, they're just like these aberrant electrical charges that basically tells the heart to beat faster than it should be beating. So that could be something that's going on. Acute coronary syndrome is kind of like the fancy word for like angina, which is just chest pain, is what we call it. And it can lead to a heart attack, right? So you want to rule out that this patient isn't having a heart attack and we're just missing it because we're so focused on psychiatry on this floor. Um, Other things are like hyperthyroidism or pheochromocytoma, which is just really big words, but these are basically conditions that'll cause increased level of hormones that can cause increased heart rate. And then an occult or hidden infection. So when your body is warding off an infection, sometimes it'll compensate by increasing your heart rate so it can deliver more oxygen and nutrients to the cells that need it. All right. And then I kind of put this other category because these can fall into either medical or psychiatric conditions, but substance abuse. So if you're using drugs, there are a lot of drugs out there that can have a side effect of increased heart rate and increased blood pressure. Does anyone know like a specific class of drugs that we typically think about with increased heart rate and blood pressure? Yeah.
Stimulants.
Great. Stimulants, nicotine, amphetamines, like cocaine. Those are the big ones that we think about. And yeah, this patient's on a psychiatric ward, so hopefully they shouldn't be using substances, but you never know. So you always want to think about that. And we always get a urine drug screen when we work up psychiatric patients. Also withdrawal. If they're using a drug regularly and then they all of a sudden stop, their body's still going to want it. So you might get some physical symptoms of what almost appear like drug use when they're just going through withdrawal from it. Another thing is medication side effects. So maybe it's not NMS, but every single medication is going to carry a risk for side effects. So you need to make sure and kind of establish a good timeline of when were you giving the medications, what was changing when, and always kind of consider that as a possibility. And then last, and this sounds simple, but incorrect vitals. So whenever there's a vital like that 165 on 99, you might want to go back and read it and just make sure it's correct. Because if the blood pressure cuff just hasn't been the right size, or maybe it's a new med tech on the floor and they just weren't taking it correctly, that could all be reasons. So you want to think about all these things that could possibly be going on. So what do you think are a good idea of things to work up? And you can just shout or type random things that you think we should look more into. If we're worried about a heart problem, do you think we should look at the heart? No takers on looking at the heart.
Yeah, I think we should totally look at the heart.
Yeah, let's look at the heart. So we're basically going to work up all of these is essentially the answer to this, which is why I was like, you guys can't get the answer wrong. So there's like a pretty, oh, and here's the slide, but I already told you what this is. We're basically going to look at everything. So one, let's make sure those vitals weren't wrong and someone's been doing them incorrect. So let's go back, measure them ourselves, or watch them take the vitals. And I saw heart ultrasound. So something that we can do is we can look at the heart with something called an echocardiogram or an echo. But usually the step before that is called an EKG. And whenever a patient has any cardiac complaints, always get an EKG. You just always want to make sure you're not missing like a giant heart attack, an arrhythmia, all of those things you should be able to see on an EKG. So here we're seeing sinus tachycardia. So sinus just means like kind of the typical shape or what you would expect, and tachy just means fast. So it's a normal heart rate, but it's fast. So we're not as worried about there being an underlying heart attack, any arrhythmias. We've kind of ruled out anything that's wrong with the heart with this. What about a CMP and CBC? Do people know what those are?
No.
No, oh my gosh. Okay, I guess I'm teaching
Complete
you.
metabolic panel.
What?
Complete metabolic panel.
Yeah, no, it's okay. That was like not judgmental at all. Also, I'm sorry if it came off that way, but I was like, oh my gosh, virtual shadowing. I need to talk more about this. I was ready to like not dive into these, but I'm a nerd, so I love talking about these things. Yeah, complete metabolic panel. So basically that's a way we look at the electrolytes in our body, and it's a quick snapshot almost of like liver function, kidney function, which we really care about are kind of those two main organs that we like to check in on to make sure they're functioning well. Because if any of your electrolytes are helter-skelter, it can kind of cause a whole other host of issues. And when we look at this, the CMP looks fine. Her liver's fine, or her kidney's fine. And especially if we're worried about drug side effects, we love to check on those too. And then CBC is a complete blood count. So this is where we're just looking at all of the different types of blood cells, which is why I say with differential, we can look at the different types. We see some mild iron deficiency anemia, nothing we're too concerned about. A lot of people tend to have mild iron deficiency anemia, especially women, due to blood loss during menstruation. And then what's a UA? Does anyone know what that is?
Urinalysis.
Yeah, urinalysis. So this is basically when you go to the doctor and they have you pee in a cup and they put a stick in it. It's urinalysis. So things that we typically look for here is a UTI. So there are certain markers, and do you guys know what the markers are that would make us suspicious of a UTI? And it's totally okay if you don't. Okay, we won't get into the weeds then, but we're worried that she's a possible UTI. Basically, there's just some white blood cells, which are reminiscent of infection, and maybe some bacteria in there. Does anyone else remember why we might be worried about a UTI based on the history?
She's been peeing a lot.
Yeah, exactly. She's been peeing a lot. So if that's not normal for her, and I believe she had told me that she's like, I keep getting up to go to the bathroom. I feel like I always have to pee. It's not hurting her, but it's not typical for her. And then a urine drug screen is the next thing we'll do. So looking at Are there any drugs that she's maybe taking and having effects for? Are there any withdrawal symptoms that we need to worry about? And we'll also just look at alcohol level, and those are all normal. How about CPK? Does anyone know what that stands for? And I did not know this before rotation, so. Okay. It's a, oh, I actually don't know what the C stands for. Creatine, protein kinase. But it's basically just looking at muscle function. So if we're worried about NMS, right, where you see this myoglobinuria, this muscle rigidity, you'll see that basically reflected in this marker called CPK, which is a sign of muscle breakdown. And then TSH is just looking at your thyroid function if you're worried about hyperthyroidism. So this is a long list of things to kind of say to you guys, but I think like the main important thing I would take here is whenever there's a cardiac complaint, if you're worried about tachycardia, hypertension, get an EKG and make sure it's sinus rhythm. Okay, so based on these results, right, we've crossed out arrhythmia or ACS because the EKG looks normal. We've crossed out hyperthyroidism because her TSH or her thyroid level looks normal. We've crossed out that big word. I just love saying it, so that's why I put it on the slide, low-key. Pheochromocytoma will have weird electrolyte findings, so we've ruled that out with our CMP. We didn't rule out infection because her UA was a little suspicious for a possible UTI. We just took a good history, and while she's anxious, because her vitals are constantly elevated, we're not as worried about it being psychiatric. If she was having a panic attack or anxiety, you'd expect fluctuations. So when she's calmer, her vitals would be lower, and we're seeing a consistent elevation, even when she's calmer in bed. We're also not worried about NMS because her laboratory vital function looked really normal, which it would be a little more aberrant if she had that. We don't think she's using drugs or in withdrawal based on her drug screen results. And we checked the vitals again, and we know that she's still tachycardic and hypertensive, and we don't know why. We can't rule out a medication side effect because is she on medications right now? Who wrote it? Who put this in there, objective or subjective? Yeah, she's on medication. She's on Risperdal, right? Or risperidone. That's the same name, just brand versus generic. Yeah, she's on antipsychotic medication. So we can't rule out infection and we can't rule out a side effect. What do we want to do? Wild guesses. We're gonna develop your assessment and plan skills tonight.
Check the before and after effects of medication, like how she's behaving before the medication and after.
Yeah, absolutely. Establish a timeline. So we've increased her medication a few times. Has her hypertension and tachycardia gotten worse? What about the possible UTI? Should we do something about that? Because maybe it is the medication, but what if she got the UTI at the same time as we gave her the medication?
Cultures.
Yeah, we could send it out to culture. So sometimes you'll order urinalysis with reflux, and that'll send it out to culture. We can also just treat it if it's symptomatic. And while she isn't experiencing the typical pain with urination or the blood with urination, having to go more frequently is still a symptom. So what we decided to do is let's treat the UTI, and this is just like a typical antibiotic you'll see people treated with is nitrofurantoin. So kind of get rid of that factor. If we're worried about that might be the cause, why not just treat it and see if once that resolves, does the tachycardia resolve? We can treat her iron deficiency anemia, which isn't consistent with hypertension, but we found it, so why wouldn't we treat it? Which there's some back and forth ethics on that, but iron deficiency anemia, you just give them a multivitamin, so it's pretty easy to treat. And then continue to monitor for medication side effects, and maybe if we keep seeing that, change the antipsychotic medication. So that was a great plan. So now let's see what happens after we do that. So the patient's UTI resolves that issue. She's no longer reporting increased frequency of going to the bathroom. She's also treated for her mild iron deficiency anemia and tolerates the multivitamin well, but her vitals are still persistently elevated. So what cause are we down to if we've ruled out the UTI? It's not in the second paragraph. What was the only other thing left on our differential diagnosis? medication side effects. So now we go back to the patient, and she's now reporting galactorrhea in the belief that she is pregnant. Does anyone know what galactorrhea is? It's a big fancy word that just basically means like lactation or milky discharge from the nipples. So she believes she's pregnant, and she has a negative UPT or pregnancy test at admission, and she has not participated in sexual activity. So I wanted to highlight this because galactorrhea actually is a known side effect of risperidone. And you will see it kind of when it starts to have a lot of effects in a patient, and that dose is like super variable for patients. So some people are really sensitive to it, and they might get, even at the lowest dose, start getting these side effects. But it can take a long time or a higher dose to see this. So when we went back and we saw this, we were like, okay, to us, that's almost confirmation that some of this tachycardia might be a medication side effect, because galactorrhea is a known one that happens when patients are having an issue tolerating the medication. And I also think this is a useful thing to tie into is she came to us and just said, I'm pregnant. And we kind of had to discern the information that she was having this galactorrhea kind of separately from that. So just because a psychiatric patient might be presenting to you with a delusion or a belief that doesn't make sense, that doesn't mean it's not rooted in an actual medical cause or something medical that they are experiencing. So now what? We're going to stop the medication, right? If we're pretty sure that's what's causing her symptoms. So we decided to transition the patient to Abilify, or aripiprazole, 10 milligrams in the morning for the management of her psychotic symptoms. Her tachycardia, hypertension, and galactorrhea resolve with improvement in thought process and content. Patient no longer endorses SI. So basically, the whole long runaround in this case is that we have a patient who's coming in with an episode of primary psychosis with a likely psychotic disorder, most consistent with schizophreniform disorder. She's experiencing tachycardia and hypertension after being treated with risperidone in the ED and on the inpatient ward. Her psychosis continues to worsen. She's continuing to experience tachycardia and hypertension and develops galactorrhea, secondary to the risperidone she's being treated with as part of her antipsychotic medication regimen. But when she's then transitioned to a different antipsychotic, it not only works better, but she's no longer experiencing side effects. Does anyone have any questions about that case? Or kind of like the timeline of what happened? Is anyone just like, oh, that's kind of boring, that it was just the medication? You can say that.
No, I actually think that's really interesting that something as like it's not her body that was really doing that. It was the medication that she was actually taking that caused this.
Yeah, and I mean, maybe especially because I know you guys probably don't have that much familiarity with antipsychotic drugs, but tachycardia and hypertension aren't actually commonly associated with risperidone. So while you might be like, well, yeah, it could be the medication, that's the only new thing here. It's not really something that we commonly see. And I'll go into the mechanisms of some of these antipsychotics as well. But we actually really so tachycardia is a fast heart rate. So it's like when your heart's racing, and it can be asymptomatic, but you're always worried about it because if your heart's working harder, that means it can tire out and you can develop an arrhythmia, or you can develop chronic chest pain, or you can have an MI if your heart's working for too hard for too long. So when we think about the way that we manage psychotic medications, something that we really want to think about is, yeah, maybe we could have just taken her off their risperidone, but if she's in active psychosis and she needs an antipsychotic, it's kind of hard to just say, let's take away the medication before working up every other thing, especially if you're worried that there could be something underlying that you're missing and it's not the medication at all. So when you talk about what aripiprazole or Abilify is, it's basically a really similar antipsychotic, but it's known to just be more well tolerated and it targets slightly different receptors. And I'll go into it a little bit more here. So I know that you talked about schizophrenia before, psychotic disorders. So to get a little bit more into antipsychotics, you have to know what psychotic things are, right? So when we think about schizophrenia, we think about the positive and the negative symptoms again. The positive symptoms we attribute to having too much dopamine in the mesolimbic system. So basically, if you have too much dopamine in this pathway, you start getting delusions, hallucinations, and this disorganized speech and behavior. On the other hand, we also hypothesize that decreased dopamine in the mesocortical, or the one that's important for thinking, is decreased. And that's where we think the emergence of negative symptoms comes. So the question then becomes, how do you treat these things, right? Because you have too much dopamine in one pathway and not enough dopamine in another. So it's kind of a really precarious situation where to treat psychosis or those positive symptoms, you have to decrease dopamine. But if you decrease it too much, you worsen negative symptoms. So it's a really fine balance that you're managing with antipsychotic medications. So what antipsychotics do is basically they target the psychotic symptoms. They'll try to decrease the dopamine in that mesolimbic pathway. So what you'll see here is, this is really complicated, I know. You'll block the dopamine receptor, and we look at a specific one called D2. And that's great. It really helps with the delusions, the hallucinations, this disorganized speech and behavior a lot of the time. But as a side effect of that, you're also decreasing dopamine in places that need dopamine, like the mesocortical pathway or even in the nigrostriatal pathway. Do you guys know what the nigrostriatal pathway is? I know I'm bringing in so many different topics today, but I was hoping this might be a little more interesting than something that was super straightforward. Any neuroscientists in the audience? No neuro people? Oh my goodness. I feel like that was such a popular major when I was an undergrad. So nigrostriatal is what we think of with Parkinsonism. No, you're totally good. I was like the only biochem major in undergrad, and all my friends were like into neuro was like the cool thing. So I figured we might have some neuroscientists. It's a pathway that's like implicated in like Parkinson disease and like weird movement disorders. And they've actually found when you actually block this D2 receptor, you activate that pathway. So you basically make these motor functions happen, which is why that motor function portion of your physical exam and your mental status exam is so important, is that you have to be really careful of this dopamine balance where you're bringing it down enough to stop those hallucinations, stop those delusions, but you're not causing these weird movement disorders and you're not causing more negative symptoms as well. So Risperdal works really, really well for psychosis, but it can have a lot of side effects. And outside of the brain, these are the typical ones that you see reported in literature. But like we just saw, you can also see tachycardia, hypertension, galactorrhea, some random things that don't really make sense just because dopamine's involved in so many different pathways in the body. And when we look at Abilify, I don't think I have a slide up for this. It's also a partial agonist. So it blocks dopamine, but it also activates dopamine in other areas, which is why it typically tends to be more well tolerated or something we'll switch to if Risperdal doesn't work for patients. So I really thought this was a great case to kind of consider, even if you're pretty sure it's a psychiatric condition causing an increased heart rate, or you're pretty sure that it's a medication side effect, always, always do a full workup. You always want to make sure that you're not missing an underlying medical cause that could be causing those symptoms. And I know that probably sounds really straightforward, but you'll see it, especially as you get exposed to different patients or you're working with a population with a lot of psychiatric illness. People's complaints tend to be dissuade, and sometimes the only way psychiatric patients can convey a medical thing that they're saying is through their own language or their own perceptions of the world. So make sure you're taking all those complaints seriously. Also, in this case, it was possible to just switch over her medication, but we've had patients on the psychiatric ward where there's only one medication that works for them, but they have really, really bad side effects from that medication. We had a 65-year-old schizophrenic woman who was really stable on Risperdal, and it was the best medication for her. But one of the side effects she was experiencing was a really low white blood cell count, which means she is really susceptible to infections. And it led to this debate, like if this is the only antipsychotic medication that works for her, we tried other medications, but she has this low white blood cell count. Do we continue it? What is our ethical liability there and what's best for that patient? And again, just be aware of medications. There's constant ones that are coming out. A lot of medications have different side effect profiles. And I didn't want to bore you guys. If you like pharmacology, I will totally be a nerd. This book, okay, it's blurred, but it says like Basic and Clinical Pharmacology by Lange is a really good overview of like the different receptors involved. And there's so much that's not known about psychiatric drugs. their side effects, why they work for some patients and not others. So stay on top of literature if it's something you're interested in, or just be aware of new drugs that get approved, because patients are so variable in the way they respond to these medications. And just like another point I want to bring up is that the management of antipsychotic medication can be so, so difficult. When someone's being started on an antipsychotic medication, it's better that they're being overseen by a psychiatrist rather than someone who only has some familiarity with it or is more familiar with mood disorders. So that is all I have for you guys today. I know that it's kind of at that hour point because I don't know. I love talking about things in teaching. So when you guys said you didn't know the terms of physical exam or mental status exam, I kind of went into it a little bit more than I had planned to. But are there any questions that you guys have, either about the case, about the field of psychiatry or medicine, or anything about my career path? I'm happy to talk about with you guys.